Hello, everyone. My name is Kojo Loko, and I'm the Executive Director of the Challenge Initiative and a member of the faculty at the Johns Hopkins Bloomberg School of Public Health. I am delighted to welcome you to this World Cities Day webinar that promises to be both enlightening and inspiring. Today, we will explore the TCI's groundbreaking approach to empower local leaders to invest in their own family planning programs for lasting change. Today's cities face complex challenges that local governments must address to ensure a bright future for all its residents. It's within this intricate web of urban dynamics that TCI's work to support local governments plays a crucial role. This year's World Cities Day theme is Financing a Sustainable Urban Future for All. This aligns with TCI's approach of engaging cities that commits their own financial resources to implement evidence-based family planning programs. At the heart of TCI's mission lies the empowerment of local governments to lead their family planning programs by scaling up high-impact practices and other interventions. TCI works through existing structures to strengthen local health systems and capacity to achieve transformative and sustainable results. Cities that join TCI not only receive technical support and seed funding, but also commit their own human and financial resources to the cause. Thus far, 176 local governments have pledged more than $100 million to implement high-impact family planning programs across 13 countries in Africa and Asia. This is a testament to the belief in TCI's model and the collective commitment to shaping a sustainable future. One of the most exciting elements of today's webinar is the opportunity to hear directly from local leaders in cities that have successfully concluded or are nearing the end of their direct engagement with TCI. They will share invaluable lessons learned from their experiences and shed light on how they have sustained the gains made during their partnership with TCI. Their stories are living proof that TCI's model empowers cities to stand on their own feet and continuing to make a meaningful impact even after the direct support has concluded. So today we'll find out about the strategies, the challenges, and the successes of local leaders from 3 urban areas supported by TCI. So we have Meerut in India, Nasarawa State in Nigeria, and Makindi, Sabagabo in Uganda. We will also hear from TCI's monitoring and evaluation team on the impact of TCI in the cities that it supports. We encourage from you active participation in the form of questions posted to the Q&A module. We will answer as many of your questions as we can, both during the webinar and at the end of the 3 presentations. So thank you for joining us today on World Cities Day as we explore the Challenge Initiative and the significant role family planning plays in securing a sustainable future for our cities. So with that, I'd like to introduce our first presenter, Sarah Alibera. Sarah is a member of the Makindi Sabagabo Municipal Council in Uganda. Sarah serves dual roles as both the public health specialist and environmental health officer. With over 12 years of work experience in the fields of public health, supervision and monitoring, she has won accolades for her efforts in strengthening health systems. Please welcome Sarah.
I hold a diploma in public health science, a bachelor in environmental health science, a master's of science in public health. I have a postgraduate diploma in hospital and healthcare management, and I also hold a master's of divinity. I must tell you that the engagement, Martin Sabagabo, his engagement with TCI started way back in 2018. That's when he started developing the PD, the program design. Then what was interesting actually after all this, TCI has a unique approach of implementing activities of the program. which approach leaves the local government to remain self-reliant. This, we call it a business unusual. Uh, Next, the program also targeted decision makers to its implementation, and this helps to bridge the gap between the technical and the non-technical for the program success. I said most of the programs that come, when the programs come, they always target service providers or the technical, leaving out other key stake decision makers who are not technical. But for Japan, right away from the start, they engaged both the technical people and the non-technical, which non-technical are very key in policy and decision making. So at all levels we're at one page, and this helped so much to create an environment for success of the program. This side brought stakeholders to the problem solving table and decision making. That at all points we had to come with our data. What do we have? How can we move forward? This is very unique. It was not a matter of coming with ideas that we have this for you. No. Come on table, talk through the problems, the challenges available, or that the challenges faced. What can we do? Not carrying a package. This is what we have it or not. No, that was not the idea. So it was really unique and very interesting. Then another point that was very interesting was the focus was on socio-economic health of the community using family planning. As broad as it may be, but we had to look at the situation. What is causing the poverty among these urban people? We are focusing on the girl child, the women who are poor, the woman who is poor in this urban setting. Sorry to mention, but most programs when they come, they focus so much on the rural population. But I've always told people that when you come to the urban center, you may find a family that may sleep hungry because right away from water is bought. You can't use firewood like here in Africa. You may go to the forest, fetch firewood or collect firewood and use it for food. But in urban, it is impossible. Where will you do the burning? On whose veranda? So with this side, they came focusing on that urban poor woman, the girl child, the teenagers. What is causing the poverty? Like me in public health, was before you talk about solid waste being a problem, who is the generator? The household. How many people are in the household? Which kind of households are they living in? Why are they living there? Are they having planned pregnancies? Is that child the mother is carrying? Did she wish to have her or it was an accident? So that approach, that focus, caused everyone to appreciate why we must have this program. Then the awareness was also a drive to the improvement of the national indicator. We have, through this time, we have repeatedly echoed the national indicators and how we contribute to them. And if we don't do something, we may do the worst ourselves. Because we live in the web, whatever we do always comes back. So wherever we are, we have something to do, and we have always been to appreciate. After appreciating people, all stakeholders, wherever they are, they can do something. Lastly, the local government commitment. Other programs when they come, which is I am bringing what was very interesting with this side. You will have a program, we have a program that is funded, you are very happy, you move on, they will fund you, but the day they go, that is everything falls because they have gone. And you will say, what is that? No, it was this program, you never left. But right away from the start, it was very clear to us that we must commit ourselves to ensure sustainability of the program, even without TSI. And they could cause us to commit, even through funding, we could commit that political will, right away from the political will to the resources. And very intention, what are you committing? Writing those letters through our chief administrator. What much in the Sabaga, what are you committing? So this one became part of us now, that every budgeting cycle they will cause, what are we committing? What are we committing? So it has become a habit during planning, or habit may sound like, but it has become uh, as our way to do things, that we must commit towards family planning. And it was all because of the approach TSI was using right away from the start, as they were beginning the project to the end. That is when we are graduating. This is interesting. There is always, when you feel a partner is moving out, there are always levels of, what should I call them, panic, or there is that feel, the feel that always comes with change. More so when the change that is coming, you may feel what next. But to us, the change was there, right? We are going to miss our partners, but we knew, according to their model and transaction, they will not go completely. They remain supporting us, and that they assured us where we need them, we can call them. So on that note, the development of coaches through training and workshops, it helped us to keep moving this other side even after we had graduated. We had developed also champions for advocacy. These people are very key where resources are very scarce, as known in economics. We need people who are ready to stand everywhere and they see family planning and they see why we need family planning and all other aspects. And we have seen this through the champion for advocacy. Then we have also continued to have the technical assistance during the implementation of the high impact interventions. Was very helpful and it prepared us for graduation. We always have what we call performance review. It is done quarterly, where people come and share their good side, their challenges, and through those performance review meetings, we know what works best, what may fail, and how can we handle. So, and also look at the different indicators, how we are performing. So appreciating all that has always prepared us, and we are ready for graduation. Data interpretation, as we meet, like in performance review, we have to look at the data, appreciate the data. Why do we have these numbers? Yet we are moving out. So all that helped us to appreciate and see how we can handle. And this was all done, and it prepared us for graduation. Use of the challenge funds as a catalyst for that, for the high impact intervention, can't be left out. And lastly, there is this magic university, the TSI University, which is always our point of reference. And it has helped us to ensure quality while we implement the high impact intervention. And on that note, with the TSI University, we have always emphasized and encouraged service providers and even other stakeholders to visit it, to register and visit it at all times. Then we come to implementing these high impact interventions without direct support from TSI, meaning we are using the institutionalized, we are using the institution money, we have institutionalized it into our work plans. This one I have mentioned it over and over. We no longer just bump into family planning activities. We are very intentional and we plan and budget for them. So data used for decision making. After we have done the performance review, like the last slide, Now we bring our data on table. Can we use it to make decision? Which area is most affected? Which indicator are we doing badly? Where can we put more money? That is during work plans, and that's where we focus our efforts. We have also gone ahead to identify the high impact interventions. There are a number of very many high impact interventions, but we have, as Sabagao, we just identified those high impact interventions that do not need funds, direct funding. Those are the first low hanging fruits we used. And these high impact interventions can bring results. For example, where through our structures we had to identify this, we have taken up the facility family planning integration. Way back as we were beginning, we had a program to bring you back what we call whole site orientation. At our facilities, we held those whole site orientation whereby all people, almost from the gate to the mortuary, if it is a level with the mortuary, people know about family planning and they can give some information. They can refer. So using that, that's where we have the family planning integrated at different serving points at different facilities. We have taken also advantage of the immediate postpartum family planning such that we don't have these missed opportunities. This is all about anyone who enters our facility, anyone who gets within our environment and needs the service doesn't go without this service. And it has really helped us. We have seen numbers. Uh, there are also these other high impact interventions we have purposely or been intention and we planned for them during budgeting. For instance, the integrated outreaches. Those ones have their funding. We are also carrying out fixed day services. These are very key and they have worked at all our levels. Then we get to the community efforts. In Uganda, there is a new program called PDM, that is Parish Development Model. When it came, I saw this as an opportunity when it comes to community efforts. And I have integrated family planning in the PDM. We have also tried to streamline family planning to the program at the municipal level, like I've said in PDM and HIV. For instance, now whenever I have a MAC meeting, that is Municipal AIDS Committee meeting, which is having a very strict budget, we are putting there family planning. There is also GBV. By policy now we have to do the GBV, gender-based violence meetings quarterly. We have always integrated it with FP. So this has helped very much. In addition, according to the guidelines of health, that is PHC fund, primary health care, 30% of the budget given to do the recurrent activities, we are supposed to earmark 30% for health promotion. And this is how we are being funded, and that's how we have managed to utilize the money to move out and give family planning services. Yes, the local government how much we committed. Yeah, this is according to how we have started. That's how we have been committing ourselves to that much. Generally, if I can put it, I think to what we commit, the best we ever achieved as per expenditure was around 64 in the first 2 years. Actually, first 2 years, especially that. Yes, but when we came to 2019, 2020, we were a bit disorganized or we got interrupted with the pandemic and we were not so good with our revenue realization. So we moved a bit low, but the good news or the good thing to hear, it is not short off. They have continued to fund with what is available. So our funding mainly depends on our locally raised revenue realization. I take this opportunity to appreciate the support from Gates Institute. That can't go unforeseen. You already see what you are doing. We're already on the recording. Thank you so much. Your support has always been felt, and I know that's why we are here, and that's why I'm here making this presentation. Thank you so much. Japaigo. Japaigo has become another name they gave me. They call me Japaigo when I move. Why? Because of the skills and the empowerment you have done that have become a better communicator and a better advocate as far as FP is concerned. The Challenge Initiative, we really appreciate your support, your coaching, your mentorship. They have not left me the same and they have not left Sabagabo, service providers and other stakeholders the same. To my own Makinde Sabagabo municipality, the environment they have created has enabled this service provision and has caused us to give what we have been filled with. Yes. Lastly, the government of Uganda, its policies and guidelines have always enabled us to do what we are supposed to do. Thank you so much.
Thank you, Sarah, for your thoughtful presentation. Next, we will hear from Dr. Akhilesh Mohan. Dr. Akhilesh currently serves as the Chief Medical Officer in Meerut in Uttar Pradesh, India. He has held this position since November 2020. Before his current role, Dr. Akhilesh worked as a general surgeon. He has rich experience in the field of public health, and currently, as Chief Medical Officer, he oversees all health programs in the Meerut district, with a specific focus on family planning, reproductive health, maternal health, and child health. Dr. Akhilesh.
Ladies and gentlemen, namaskar, good morning, good afternoon, good evening all. I'm Dr. Akhilesh Mohan, the Chief Medical Officer of Meerut. I'm a general surgeon by training, but I'm a dedicated social worker also. I'm posted in Meerut for last 2 years and 9 months. Meerut is not just a city, it is a community with diverse needs and aspirations. According to the 2011 census data, the population of Meerut is 3.4 million, out of which 1.3 million is urban. The city has been actively working towards strengthening its health systems. We have at present 26 UPHCs, urban primary health centers, and 48 urban community health centers. So the system is strengthening. The city has been working, my devoted team and I have been overseeing implementations of various health programs, and this is one of them. We look after the rural as well as the urban populations. As we celebrate the World Cities Day, it is essential to recognize and appreciate the collective effort that has been gone into enhancing the urban family planning and urban health services in our city. Today, Meerut has transformed into a city where health is not just a service, but a shared responsibility. Meerut has progressed well in various health indicators of family planning. One of the major indicators is 5% growth in MCPR, as per the National Family Health Survey, round 5. With fast decadal growth of urban, it was not easy to cater to the health needs of urban residents. We did it to a great extent with collaborative effort of various stakeholders. It is with great pleasure and pride for me to present before you the processes and achievements of my city. In August 2018, the city started a collaborative journey with PSI India under its impactful project, the Challenge Initiative. with an aim to strengthen the urban health system. I was not the chief medical officer then. Dr. Rajkumar who was my predecessor, was the chief medical officer then. It was under his leadership that the program had started. Our first initiative was the facilitation of city consultation workshop. This workshop served as a key platform for a comprehensive understanding of a city. We involved various stakeholders for the gap analysis to assess the prevailing scenario and identify the strategic priorities aimed at strengthening the system. As a prioritized initiative, we introduced India's high impact interventions, such as implementation of fixed day static services of family planning that was initially started in selected urban health facilities, but now they have been expanded to all urban health facilities. Encouraged by these positive outcomes, we systematically intervened into all these systems. Today, 100% primary health centers have these facilities, which is the day of Thursday has been fixed for the FDS. Simultaneously, with technical support from TCI India, we initiated the activation of the convergence platform called the City Health Coordination Committee, with a collaborative effort by involving all the relative departments in our district, which includes the ICDS, the DUDA, Nagar Nigam, and Department of Education, which directly or indirectly have been involved in this program to review the progress. And on the other hand, we established an activated quality improvement and data validation committee at facility level to improve the quality of services and data reporting. The service providers were not very well versed in the beginning, but with this training and validation of data, things have improved. All primary health facilities conduct QI and data validation committee monthly meetings. Through whole site orientation for health facility staff, we created an enabling environment and enhanced the uptake of postpartum family planning services in district hospitals and medical colleges. We have these facilities in our rural areas also. A true noteworthy step in our journey was the establishment of cadre of mass coaches within our healthcare system. These master coaches are professionals who hold responsibilities to implement different aspects of urban health programs. Their pivotal role involved not only the implementation of high impact interventions, but also the provision of need-based coaching support to fellow staff members. This dynamic approach of coaching and mentoring ensured health system strengthening and sustainability of high impact interventions. We will discuss more about the role of master coaches in further slides. After the completion of 4 years of TCI India support in August 2022, Meerut City successfully graduated out of the TCI model. The result of these initiatives yielded a remarkable surge in the uptake of family planning services. According to health system data, the annual client volume witnessed a threefold increase from 8796 at the time of initiation of TCI India partnership to 33,078 as of August 2023. It's noteworthy to highlight that since graduation from TCI India program in August 2022, the annual client volume has increased from 28,578 to 33,078. That's a great jump. Another notable trick indicating improved family planning initiatives, increased awareness, enhanced access to contraception was an increase in net contraceptive uptake, rising from 0.02 to 2.12. The data clearly demonstrates the resilience and sustainability of the high impact interventions and practices. Next slide, please. At the core of our health system, strengthening efforts are the master coaches. They are equipped with a clearly defined responsibility matrix. These master coaches diligently convene regular meetings to evaluate progress at facility and city levels and develop coaching plans, ensuring the transfer of skills and knowledge. In Merit, the data serves as an essential component for decision making in various forums, including NUHM and FP review meetings, Triple C meetings, and public private interface meetings. Crucially, the high impact interventions that have proven effective are now integrated into the budget through the program implementation plan, such as fixed day static services in the form of Antaral Divas, ASHA and A&M meetings, as well as Triple C meetings. The rigorous tracking is also a crucial step, which implement in HMI's data reporting, oversight by the data validation and QI committee at facilities, monitoring family planning service uptake trends, and ensuring the seamless logistic and supplies for family planning products. This year, Meerut was declared as a playground city, serving as a model for other cities to learn from our successful endeavors in urban family planning and urban health systems. Recently, the directorate team of Uttar Pradesh visited the city. They motivated us to share our initiatives and achievements to other regions within the division. To learn from us, officials from Bulandshahr team visited, and we also had a pleasure of hosting Kate Grams from Gates Institute. The city leveraged lessons learned and challenges to continually refine and enhance our approach to urban health system strengthening. Building upon these experiences, we have emphasized on the clarity of roles within the master coaches, fostering a sense of ownership and commitment to our shared objectives. We have the mechanism in place at cities and city level to plan and review the family planning component in our urban health agenda, such as NUH and family planning review meetings. ICCC meetings and DHS meetings are some of the key platforms that are used to review the progress, like the decisions and drive the corrective actions. We have this DHS every month. We have also seen remarkable increase in the commitment and expenditure in family planning and NUHM programs in the city level in few years. We have strong coordination with divisional, PMU, and state NHM officials, and that gave us an edge to get the things done in quick manner, increasing demand from the community and achieving expected level of results by the district. We are the key to leverage increasing funds to execute the programs at the city level. To facilitate continuous improvement, we have also instituted a robust reflection and feedback mechanism within the city, which focuses on prioritization and performance. We also established coordinated and other efforts that ensure a collaborative effort towards shared health goals. This includes fostering intervertical coordination, break down silos to promote holistic healthcare solutions in Merit. As I have said earlier, our decisions are anchor-driven and data-driven insights. Thank you for your attention, and let us continue our collective efforts for healthier, and happier cities across the world. Thank you.
That was a wonderful presentation, Dr. Akhilesh. Next, we have Dr. Absalom Madawa. Dr. Madawa currently serves as the Director of Community Service with the Primary Healthcare Development Board in Nasarawa State, Nigeria. Throughout his career, Dr. Madawa has made significant contributions to public health, particularly through his roles at Jos University Teaching Hospital and as a medical officer at Dalhatu Araf Specialist Hospital in Lafia, where he focused on HIV/AIDS treatment and care. Dr. Madawa also contributes a significant portion of his income to philanthropic work and volunteers in counseling and health education for adolescents. Please welcome Dr. Madawa.
My name is Madawa Absalom, and I work as Director of Community and Family Health Services at the Nasarawa State Primary Healthcare Agency in Lafia, North Central Nigeria. Our state is called Nasarawa State. And then just to say that our partnership with TCI began in June 2020. This followed a written expression of interest that was sent to TCI, following which we got positive response and we were asked to submit a program design. Well, I will say that in the 3 years that we've been having this partnership, some very key things have been interesting to me. First and foremost, I will say the business unusual approach, which targets from the very beginning, targets sustainability. For me, makes the project a little bit different from those projects that we are used to. And with this project, we, the government, take the lead while TCI provides TA to us through coaching and mentoring. The other thing that I find interesting is the challenge fund, where there is matching fund from TCI while we as government provide counterpart funding. The TCI University also, we find very, very, very interesting because of the resources that are available there and the capacity of our officers that has been built as a result of these resources. In terms of readiness for graduation, I think we are very ready and we're excited at the opportunity to showcase what we have learned from the TCI project. And all of these are there, these resources that we have gotten from TCI, the TCI University, the mentoring and coaching. We are just very willing and ready to just start implementing them and see how we are able to do that on our own without the technical assistance of TCI. We are happy at the opportunities that we have to implement the high impact interventions, such as the enriches, the demand generation, whole site orientation, and all of those high impact interventions. We see the state really moving forward with this because even as TCI has not graduated us yet, we have taken the lead in terms of these high impact interventions. For instance, we had 35 TCI demonstration health facilities, but with the state has taken the lead and has scaled up to an additional 65 health facilities. I think this is all thanks to the kind of coaching that we got from TCI. Also, we have, in terms of the demand generation activities, we have the CHIPS program where we have CHIPS agents. So CHIPS is Community Health Influencers, Promoters, and Services program. What happens with the CHIPS program is it's just similar to what you have with community health workers in other countries. But in our country, we call them CHIPS agents. Now, talking about the technical management and coaching that we got from TCI, I think I pretty much mentioned a good I said quite a little about that previously. It's been eye-opening to us. Our capacity has been built over time. And in doing all of this, the good part is that the state takes the lead, while TCI just does the hand-holding and providing the technical assistance. Like I said earlier, the project is designed such that at the very beginning, at the get-go, we're already looking at sustainability. So based on that, we know that we need to carry forward with the interventions on this project and some of the coaching that we have received. So knowing this, we had to come up with plans that will help us to ensure that we carry out these activities post-graduation. So for us in Nasarawa State, we have Nasarawa State Strategic Health Development Plan, which is very recent. We just we came up, we completed this strategic plan in August this year. And then it's a roadmap for us in the health sector. We also have the costed implementation plan for family planning from 2021 to 2024. So the costed implementation plan serves as a rolling plan for us. It highlights our family planning priorities in the state. And so we use what we have on the costed implementation plan to guide the development of our annual operational plans on a yearly basis. The other thing I want to mention here is that the facilities that we have scaled up to are actually our priority facilities. So for us in Nasarawa State, out of the several facilities that we have, we chose a specific number to be our priority facilities. They're just under 200 facilities. But the first level of these facilities are those ones that we have in each ward, one PAC per ward. So they are 147. And so far, the TCI project focused on 35 facilities, but you can see now that the state has scaled up to an additional 65. So in total, we have 100 facilities now. And then we have monthly plans that are developed for in-reaches, for whole site orientations, and we monitor the facilities to track and see how much or how many of these facilities are able to conduct the in-reaches during the course of the month. Our government has demonstrated commitment to family planning, and this is proven by the creation of budget lines for family planning across the MDAs. MDAs here means ministries, departments, and agencies under the Ministry of Health. So we have the Ministry of Health, we have our agency, we have the Hospitals Management Board, and then we have also agencies like the Health Insurance Agency. So we have budget lines created for family planning. We also have ensured that all our facilities procure consumables, family planning consumables, so that we are able to provide free family planning services to the clients that come to the facility. We have also established an interfaith forum in the state that helps carry out the messaging on family planning to churches, to mosques, and with that, we have seen that the uptake for family planning has been on the increase. There is a willingness on the part of our government at the state level to also implement one of the federal government policies on health that requires that at least 1% of our health budget is dedicated to family planning. So we are on course to making that happen in our state. So far, from inception of the TCI project to now, our government has committed over 300 million naira to family planning. In terms of dollars, that is about 673,000 US dollars. And this has increased over the course of the last 3 years. Well, it's not just about funding. We have also seen family planning uptake, go up since the project began. So in 2021, so the data for 2019 is not very okay because of what happened with our HMIS tools. We changed from version 2013 to version 2019. And so as at that time, the health facilities did not really understand how to capture the data. So we do not have something that looks meaningful for 2019. Also, you recall that in 2020, the pandemic affected, the uptake of services. So, but from 2021, we had uptake of over 161,000. And then 2021 we had over 139,000. In 2022, it increased to over 161,000. But as I speak right now, the data from January to September is about 132. If you look at this, there has been some considerable increases over the years. Also, this is proven by what we have on our contraceptive prevalence rate. In 2018, the CPR was 14.3%, but as at 2021, it has slightly increased to 18.4%. The other thing I want to mention about our commitment is the fact that we have identified and decorated family planning ambassadors in the state. We identified 8 of them, and we have decorated 5. 3 are still outstanding, and we intend for that to happen before the end of the year. We have also commenced family planning mentoring visits to health facilities, specifically around postpartum family planning. We still think that there is room for improvement in terms of family planning fund release. So we are targeting advocacy at the executive governor and the deputy governor. We are lucky that the deputy governor is a medical doctor, so he understands family planning. We are also engaging with other important people in the hierarchy of the state when it comes to fund release. We also want to use our strategic health development plan and this costed implementation plan for family planning as advocacy tools. One thing that we've been doing that has helped us over the years to unlock resources has been the engagement of the Ministry of Finance in everything that we do. So they are always at our family planning, our annual operational plans development, and even during the strategic plan development, we had representation from them. We also think that engaging the Interfaith Forum and the family planning ambassadors will go a long way, and will be useful to us in terms of advocating to the government for more fund release. And there is this there is a law that establishes our agency that makes provision of 2% of the total funding coming to the LGAs to be given to us, to implement our health programs. So far, only 1% is being given. So we want to advocate and see how that can be increased to 2%, and the funding will increase. And I definitely believe that more funding will be committed to family planning. We also have this biannual engagement with our PAC stakeholders. That is done on a 6-monthly basis. We want to reactivate that because the more they understand what we are doing, the more they will be willing, to commit and resources to us, and also ensure that funds that are budgeted are also released to our agency. So by and large, I think those are some of the things I want to say about how the TCI project has positioned us in the state and how we are doing with the programming right now. and also prospects that we think are available to us. Thank you.
Thank you for sharing the picture from Nasarawa State, Dr. Madawa. We will now hear from our last presenter today, TCI's Senior Research Data Analyst, Jessica Mirano. Jess will show us how the cities that have ended or are nearing the end of their engagement with TCI are faring. Take it away, Jess.
All right, thank you, Kojo. At this point, we would like to share the overall picture of what TCI is seeing to date around sustained impact in our supported cities. As of June 2023, TCI has a total of 87 graduated cities, most of which are coming from East Africa and India, with 38 and 31 graduated cities respectively. Meanwhile, Nigeria and Francophone West Africa have 10 and 8. Cities from Pakistan and the Philippines, the two newest hubs of TCI, have not yet gone through graduation. Among the graduated cities, the months since graduation ranged from 1 to 37 months, with a mean of 21 since graduation from TCI, as you will see on the table in your right. In this presentation, we will answer some preliminary questions of interest around our impact in these graduated cities. These questions are shown in this slide. While there are many important aspects of impact, our presentation focuses on TCI's lead key performance indicator on modern contraceptive uptake. Specifically, we look at TCI's HMIS-derived indicators on additional family planning clients, as well as net contraceptive uptake, or NCU. Question 1 asks, how many additional family planning clients are still coming from graduated cities since their graduation from TCI? Question 2 focuses on whether the graduated cities still show positive contraceptive uptake since they graduated. The third question looks into whether the graduated cities achieved the NCU projection of 1.6 per 100 women of reproductive age, or WRA, which TCI projected in 2020. And lastly, we will see whether the graduated cities show an increased rate of contraceptive uptake after graduation compared to during the TCI engagement period. For question 1, we see that out of the 3.48 million additional FP clients since TCI implementation until June 2023, a total of 588,903 came from the graduated cities since they graduated from TCI support. That means that around 17% of the results seen by TCI is still coming from its graduated cities. This is further broken down by hub in the table shown here. For questions 2 to 4, we focused on a subset of 79 TCI cities with at least 12 months since graduation. We see that about 68% of graduated cities are still showing positive contraceptive uptake since their graduation from TCI support. This is highest in India and Nigeria, with at least 80% of cities demonstrating a positive number of additional family planning clients since graduation. Even West Africa is showing that 3 out of 4 graduated cities still have positive uptake. TCI's global and East Africa teams have already been investigating what challenges some of the graduated cities are facing in this region, including stockouts, but we see that a bit more than half of East Africa cities are still showing positive uptake. TCI also made a projection at the beginning of its bridge period in 2020 that graduated cities will achieve an NCU of 1.6 per 100 WRA. With our data until June 2023, we see that about 47% of the cities achieved this NCU. This is higher in Nigeria and India, with 60% and 52% respectively, while Francophone West Africa continues to face some challenges with contraceptive uptake, including HMIS reporting, stockouts, and strikes within their graduated cities. TCI is already looking into the types of coaching on demand support that can be provided to graduated cities that are facing challenges to sustain their results. And lastly, we also wanted to investigate this ambitious question of whether there is an increasing rate of additional family planning clients after the city graduated from TCI support. This means that their annualized NCU is even higher after graduation compared to during the period of engagement with TCI. Here, we see this is happening in about 1/3 of TCI cities, which is really encouraging on us on the sustained impact within these cities. It would also be interesting to do this analysis vis-a-vis their period of engagement with TCI. So overall, the preliminary analysis is showing some promising signals of sustained impact post-graduation, while also helping TCI identify areas that may need coaching on demand and other technical or managerial support. TCI will update this analysis regularly and identify other questions of interest to monitor how our graduated cities are faring. Aside from the analysis I showed in previous slides, we also plan to investigate the following in graduated cities. We want to look at their continued implementation of high-impact practices and high-impact interventions, looking at their local government commitment in spending after graduation, continued coaching needs from TCI, if any, and also their RACE scores, which is their local government self-assessment of various domains of sustainability. So with that, I would like to thank you for your time, and I'm handing it back to Kojo.
Thank you, Jessica. I'd like to thank all of our presenters for taking the time today to demonstrate the critical role local governments play in financing a sustainable urban future for all. TCI's approach to mobilizing local resources for family planning is indeed improving the lives of those living in urban communities. Now, my colleagues Kate Graham and Kim Martin will facilitate our Q&A session. Please use the Q&A module to ask your questions. Over to you, Kate and Kim.
Hi, my name is Kim Martin, and I lead communications for TCI, and Kate and I will be facilitating the Q&A. Our panelists will continue answering specific questions in the Q&A module, but we would like to ask each one of our speakers a few final questions. Our first question goes to Sarah. Sarah, what do you do to advocate for continued support of family planning programming now that your TCI support has ended?
Yes. What we have done to continue supporting is mainly through advocacy, using the environment, the ethics, and the evidence. We have tried to always shout and bring out the picture of what is happening in our slums. Yeah, when you create through media and presenting what is happening to the urban poor woman, you create that response, people to respond to what is happening. It is until you bring the whole image. When you bring the whole image of what is happening outside there, all the key decision makers are ready to support. Another thing, we have also used a lot of media, more so now the social media and our national media, to bring out the image, how we contribute to the national indicators, how we can do better through family planning and other services rendered under there, more so using the high impact interventions. So that's how we have continued, mainly is to bring out what is happening outside there to the key decision makers. Advocacy.
Thank you. Dr. Absalam, what did you think of TCI's coaching approach when you were implementing the high impact interventions as you moved towards graduation?
Okay, so I think I pretty much mentioned that during the presentation that was earlier played. I thought it was very, very useful. It showed to us
a lot of things that we had not paid attention to. So, for instance, we saw through the coaching and mentoring that there are very, very simple, high impact activities that we either had not taken very seriously or we never knew could really have great impact in terms of our family planning uh, uh, programming in the state. So very simple things such as whole site orientation. Those are things that we really never bothered, to take very seriously before, but we have seen that change a lot for us. We've also seen also another simple activity as enriches, just creating awareness for people and focusing on a particular day to provide family planning service. Uh, calling them out using the various channels that we have, like the chiefs agents, the town announcers around the health facility coverage areas. We have seen that change a lot. Coaching and mentoring, going to the facilities, looking at what the facilities do, checking their record, cross-checking that on what is on the DHIS2, which is our national data platform. We have seen that done a lot. So there are several examples, but I give one. So there is this particular facility that our state program coordinator and some of our officers went to, and they found out that on the DHIS2, it showed that in a particular month, they had seen 6 clients for family planning. But, digging into their registers, their work, they found out that they had 24 clients that month. So they only recorded a quarter, of what they had done during the month. And that has been the story looking at several other facilities. So whatever we present, in terms of data for family planning, with the way, our data system has been over the years, we think we are underreporting. But we have plans, to better our data. We have put in place various mechanisms at various levels, health facility level. At health facility level, what we have planned to do, and we are about getting that done within the shortest possible time, is to engage data officers for the health facilities, qualified data officers, those who have training on health information management these are health information management technicians who we feel will handle the data better. At the ward level, our data validation has not been very, very good. What we used to have is to have data validation at the LGA level. And for your information, we have in some LGAs over 100 facilities. And this data validation is done, in a particular day in a month. And you and I know you cannot validate 100 facilities data in one day. So what they usually do is just sit down, chat, and then come up with figures. So we believe that if we do data validation at the world level, it will provide for us something closer to what we have, from the facilities. We have an average of about 3 to 4 facilities per ward. That is easier to do than doing 100. Then the other thing is also to have HMIS officers at the LGA level. We have already engaged them. We have trained them. They have had one training already. So we are just about, rolling them out and getting them to do the work of data validation and reporting for each LGA. The M&E officers that we have as at now, they are the busiest sets of officers that we have at the LGA. So we believe that if the HMIS officers are delegated with the task of just focusing on the data, then definitely what they report to the DHIS will be much better than what we are having. So those are some of the things that, during the course of our coaching and mentoring, we have tinkered with, along with the TCI officers that work in our state. And we have agreed that these things will make our work even better going forward. Thank you.
Thank you so much, Dr. Absalom. That was a really great point. And hi all, my name is Kate Graham. I am the program manager for TCI, and I would like to ask a question for Dr. Mohan about graduation and, how the activities have continued. So I'd like you to maybe just share a little bit more about how you've been able to continue to implement these high impact interventions with, having graduated from TCI. Do you see that they are now institutionalized within your work plans and your PIPs?
Yes, you're right. These things have been institutionalized in our work plans. We have several people to train. The lowest level or the ground worker is ASHA. The ASHA brings the patient, find out the people who have to be given these family planning services. They have been trained by our master trainers, master coaches. They have been trained in a way so that the eligible couples whom they identify, they bring that to the ANMs, auxiliary nurse midwife, which is also the backbone of our health system. These ANMs further scrutinize these patients. They give the services themselves after the training. But if still they need some other help, or a person who is eligible and is not being yet convinced by the two, that person is brought to the medical officer who is in charge of the urban PHC or the other centers in the urban areas. That includes our district hospital as well as the medical college. So the system here is to try, influence, evaluate, and thereby pass on the facilities regarding family planning to the persons. That is how TCI has helped us to influence almost the society through our master coaches and the coaches. Thank you.
Great, thank you so much. And just kind of a follow-on quick question. There are a few questions within the Q&A about the support that TCI provides after graduation. Can you speak a little bit more about if you receive support, maybe on-demand coaching from TCI?
TCI at this point of time is giving a mild type of support. That is not the actual support as it did in the beginning regarding coaching and all that, but it is a small support, a slight support, which they are giving us at this point of time.
Wonderful. Thank you so much, Dr. Mohan. And Kim, back to you.
Yeah, I have one more question I think we can get to before we wrap up. And this one is for Sarah. In most African countries, the governments have been committing resources for different health activities, but the challenge has been disbursement. How much was dispersed for the planned FP activities, and how much was contributed by the donor-funded project?
Oh, thank you, Kim. Looking at our budget we are running, we mainly consider we have a guideline under health promotion where we have to commit 30% of our budget line, under that is primary health care, towards healthy promotion. And on that same money, that's what we have purposely intended to use on FP. Our budget line this financial year, that is 2023, 2024, we are actually public health department. I'm running a budget of around 2.4 billion, meaning out of that money, I must commit. If I receive around 500 million Uganda shillings, I must commit 30% towards the health promotion, and that's where reproductive health and family planning is run. That's what I can really give at the moment. We run by guideline, and that's what we follow.
Okay, and what was the donor contribution? What was the contribution from TCI?
From TCI, this we being that we graduated, this financial year I'm talking of, we have no straightforward funds from TCI, but we have received support from them, mainly through we have been looking at smart advocacy, such that we find money from the other private sectors through the strategy of public-private partnership. This financial year I'm talking of, we didn't receive straight funding from TCI, having graduated.
Right. Thank you so much. And over to you, Kate.
Wonderful. Thank you so much. I want to thank all of our panelists here today, Kojo, Jessica, Sarah, Dr. Akhilesh, and Dr. Absalom. Thank you so much for being here with us today. I know that the time zones are different everywhere. It's afternoon and evening, so we really appreciate your time and sharing the vast experience that you have, as well as, what's going on the ground. We really appreciate it. I also want to thank all of our attendees today for sticking with us throughout this hour and 15 minutes. We appreciate your participation and your questions. So with that, we will close out. We will share a recording from this webinar. And if you have any questions, do feel free to reach out to us at Global or any of our panelists as well today. So thank you so much for your time, and have a wonderful rest of your morning, afternoon, and evening.
Thank you.
Thank you.